Musculoskeletal injuries are very common and can be caused by direct force, indirect force, or twisting force. Treatment for musculoskeletal injuries includes a series of steps to minimize further damage to the fractured bone and the surrounding soft tissue. Splinting is an effective, immediate emergency care procedure for all suspected extremity fractures. These icons represent the individual steps for musculoskeletal fracture management. Pay special attention to them as you will be tested later in the application. Take body substance isolation precautions. Prior to the procedure, take and verbalize body substance isolation precautions and put on protective gloves and goggles. Expose and assess the injury. Manually stabilize the injury, then carefully expose the injured area. Cut away clothing if necessary and control any bleeding. Signs and symptoms of musculoskeletal injury include pain, tenderness, deformity, swelling, bruising, exposed bone ends, and obvious signs of bleeding. Inspect and palpate the patient to determine the type of injury. The injury might be a fracture, dislocation, sprain, or a strain. Fractures can be classified as open or closed based on whether the skin is open. A fracture in which the bone is broken in several places is a comminuted fracture. An incomplete break in the fractured bone is called a green stick fracture. Note, green stick fractures are uncommon in adults, however often occur in children. An angulated fracture is when the broken bone is bent at an angle. A dislocation is when a joint is disrupted or coming apart. A sprain is the stretching of a ligament in a joint. A strain is the overstretching of the muscles. Note, before focusing your attention on musculoskeletal injury, remember to perform the initial assessment of the whole body to rule out obvious life-threatening injuries. Assess distal CSM. Before splinting, assess CSM. Distal circulation, sensation, and motor function. Diminished function of the extremity may be a sign of an injury that has compromised circulation, motor function, or nerve function. Check the circulation of the upper extremities by feeling for a radial pulse. Check the circulation in the lower extremities by feeling for the posterior tibial and dorsalis pedis pulse. Assess distal motor function by checking the patient's ability to move their hands or feet. Assess the strength of the hands by asking the patient to squeeze your fingers. To assess the strength in the feet and legs, ask the patient to push against your hands. Assess the distal sensation by touching the patient's finger or toe and ask the patient, which finger or toe am I touching? If distal function is compromised, proceed to the appropriate intervention. Realign the deformed extremity. If a pulse is present, Splint the injury in place. If a distal pulse is not palpated, you may attempt to align the injury one time to regain circulation. With gentle traction, manually align long bone injuries to the anatomical position. When aligning the extremity, grasp the distal extremity while your partner places their hands above and below the injury. Next, pull gentle manual traction in the direction of the long axis of the extremity while your partner supports the injury site. Apply tension until the extremity is properly aligned. Stop the realignment if you feel resistance or if you suspect the bone may puncture the skin. Note, do not push protruding bones into place. Splint the extremity. Choose an appropriate method of splinting based on the severity of the patient's condition and priority. If the patient is low priority for transport, you can carefully splint each site individually. For a higher priority, you may secure an arm to the torso or a leg to the uninjured leg. For the highest priority and fastest method of splinting, secure the entire body to a long spine board. To immobilize a long bone, be sure to gather cravats, padding, and roller bandages. Next, measure and align the splint alongside or under the limb. Apply and secure the splint to immobilize the joint above and below the injury. Secure the splint using cravats. Position the cravats above and below the fracture site and tie the tails of the cravat in a non-slip knot on the outside of the splint. Secure the ends of the tails into the cravat. Secure the limb in the position of function. To manage a femur fracture, it is recommended to splint the limb with the unipolar Sager or Kendrick traction splint, or with a bipolar splint such as the Hare or Fernotrac splint. Indications for a traction splint include painful, swollen, and deformed mid-thigh with no joint or lower leg injury. Contraindications include pelvis, hip, or knee injury. To apply the Sager traction splint, place the splint medially along the leg. Measure the splint with the uninjured leg and unlock the clasp to adjust the length of the splint. Next, secure the thigh strap and wrap the ankle harness above the ankle. Secure the harness under the heel and pull traction until the pain is relieved or the pressure is 10% of the patient's weight up to 15 pounds. If you are applying traction to both legs, pull until pain is relieved or to a maximum of 20% of the patient's weight or to a maximum of 30 pounds. Before securing the patient to the spine board, secure the straps and strap the ankles and feet together. Other types of splinting include vacuum splint, joint splinting, pelvic wrap, longboard splint for a hip fracture, air splint, pillow splint for an injured ankle, and sling and swath method for shoulder girdle injury. Reassess distal CSM. After splinting is complete, reassess distal CSM. Assess distal circulation, sensation, and motor function. Pad the voids. Fill the empty spaces or voids between the splint and the patient's body to increase protection and comfort. Transport the patient. Do not delay the transport of the patient. Perform the more detailed exams and care procedures during the transport. Monitor and check the vital signs every 5 minutes for an unstable patient and every 15 minutes for a stable patient. Be mindful of the hazards of splinting. Splinting before life-threatening conditions are addressed. Applying a splint too tightly, injuring nerves, blood vessels, and soft tissue. And applying a splint too loosely, causing further bone injuries.